everyone. I have Assistant Professor Deniz Gökalp from Liv Hospital in Istanbul today with me, and we are going to discuss about IVF and assisted reproductive techniques which are available nowadays for couples who are struggling to plan a pregnancy, and the issues that they commonly face, the success rate of IVF, and what kind of assistance is nowadays available for them. So thank you so much, Dr. Deniz, for joining us today for this informational video.
You're welcome. Hello.
Okay, so my first question to you would be, what are some of the latest advancements in the field of, assisted reproductive techniques in IVF, which is available nowadays for people, and which has considerably improved the success rates as well?
Yeah. Assisted reproductive techniques field is expanding enormously, and technology has has brought many new eras to this field, of course. As infertile couples struggle with having a child, everybody knows that we get an egg from the lady, sperm from the husband, do microinjection and produce embryos and transfer to the womb. So this is the basic form of IVF, in vitro fertilization. So everybody knows that. But recently, more and more advanced techniques in forming the best quality embryos are rapidly increasing. So our lab standards are much higher than it used to be compared with the past. The way we handle the gametes, I mean the sperm and egg, has changed. The culture techniques, I mean the way of incubating the embryos in the lab, has changed. The genetic assessment of the embryos with the help of the very newest genetic platforms, now we're able to screen all 46 chromosomes, and we are able to tell if an embryo is completely healthy in terms of chromosomal structure and number. We can screen many genetic diseases inherited from the father, mother, or caused from a pathogenic mutation carried by father or mother. We are able to freeze and thaw, again freeze and thaw. The freezing thawing techniques has improved a lot. We can, in the past, we used to tell the patients that thawing an embryo, transferring a frozen thawed embryo would minimally decrease the chances of success rates, the success pregnancy outcome. But now, even higher pregnancy rates are being reported when you do the frozen thawed embryo transfer. As if we pause the time, I mean, when you thaw the embryo, there's no deformation, no degeneration. The embryo goes back to the old original state so quickly and so in a very healthy way. So when we do the thawing and freezing and thawing and freezing this in a successful manner, there's a lot of different treatment options. For example, back-to-back stimulations, embryo pooling, embryo collecting, stimulation in a random way, especially considering the poor ladies with poor ovarian reserve. So there are new techniques about stimulation as well, shortly. So this, of course, all this improved our rates, the outcomes, in a very positive way. So shortly, lab techniques, genetic screening, handling the gametes and the embryos in a different way, freezing and thawing techniques, we can count shortly. These
Okay,
are the
okay.
new recent
That's
developments. Mhm.
That's very good to know because one of my questions was also about the genetic screening of the embryos because we get a lot of requests from couples who specifically want to choose for IVF for the purpose of genetic screening, wherein they have both of them are carriers for sickle cell, for example, and they do not want a child who suffers from sickle cell disease. So that's very much possible nowadays.
Exactly. We are especially very specialized in embryo biopsy, and right after the biopsy, sometimes the genetic results do not come so quickly, so you have to freeze the embryo after taking the biopsy until you receive the test results. And then, depending on the results that arrive us, we thaw the healthy embryo and do the transfer. This is called uh, single gene disorder screening. The example that you gave, the sickle cell disease, for example, is a single gene disorder. There are many other examples: metabolic diseases,
Right.
muscular dystrophies, hematologic diseases, uh, cystic fibrosis, especially in countries where I think, like Turkey, India, has some um, marriages which father and mother are related. Uh,
That's
the relationship. Mhm.
Yeah, in the Middle East as well, it's very common for babies to inherit disorders in such cases.
Exactly,
Right.
exactly. So, yeah, we do for many different reasons. We do a lot of genetic screening. So maybe in with one sentence, I would define my IVF center as an advanced genetic um, screening plus reproductive health clinic.
Okay, okay. So, considering there is no genetic diseases involved, or they do not want to go for any kind of genetic screening, but there is a couple who wants to undergo IVF because they have been, trying to conceive since last 1 year, 2 year. They're suffering from unexplained infertility. So, what's the criteria for choosing a couple for IVF? And what kind of screening should they undergo in their home country to be able to decide that yes, this is the option that they have and they should be undergoing IVF.
Yes. If the woman's age is under 35 and she has already, let's say they have an unexplained infertility, which means ovarian reserve tests are normal, ultrasound is normal, sperm is normal, and the woman's fallopian tubes are open, I mean, not blocked. So there is nothing you can explain in this couple which can show the reason of the infertility. Then this couple is suitable for intrauterine insemination. In their home countries, they can at least try a few rounds of insemination because we do the same way here. We suggest inseminations first. If the tubes are open, sperm is normal. Uh, if the inseminations fail, then of course we suggest them to move on with IVF treatment. But if there is very obvious reason for the infertility, regardless of age, let's say low sperm count, blocked tubes, or endometriosis, or low ovarian reserve, we don't usually waste time with insemination and move on to IVF directly. So for us, there is A, B, C, which is A is the woman's egg count or ovarian reserve. So we want tests like FSH, LH, E2, or anti-mullerian hormone AMH testing. We
Mm-hmm.
want a transvaginal ultrasound from a local OBGYN specialist, and we want a sperm count, and we want HSG film, which is the film that shows the tupal patency.
Mm-hmm.
Okay, so for this hormone sperm analysis and HSG film, we can decide and invite or suggest a local milder treatment within the home country. So,
Mm-hmm.
but the ladies who are above 35 should not
Mm-hmm.
wait more than 6 months. Uh,
Mm-hmm.
if they cannot get pregnant within the 6 months, these tests should be done earlier. I mean, you don't have to wait for a full year or two to
Mm-hmm.
perform these tests. So
Mm-hmm.
based on these tests, we can provide them information about what to do, what should be the next step.
Mm-hmm. Okay. So sometimes the couples they're working and they do not, they cannot take leave for more than 2 weeks, and they cannot plan a trip for about 1 month to complete the entire IVF cycle. So it's their decision to get embryo freezing done, and then they can travel in the next cycle to get the embryos placed. But if I talk about the difference in terms of the success rate between frozen embryo transfer and fresh embryo transfer, is there any difference between them?
No, we get our success rates, pregnancy rates. I mean, pregnancy rate per patient that embryo transfer was done. We calculate them every month, and every month, always, frozen toad embryo transfer is either equal to or greater than the fresh transfer cycles. So we
Okay.
have no doubt about it. So
Mhm.
your patients, your clients should not have any doubt about, well,
Mhm.
what if we freeze our embryos? Would it harm them? Would it over our success rates? No, it won't. It will not. Okay, if an embryo is already a good quality embryo, it loses nothing from the quality just because of freezing and thawing.
Okay, okay, that's a kind of a relief, I'm sure, for the people who will be watching this video later on, because this is one of the most common questions that we have, that freezing the embryos would harm the embryos in any way, it would reduce the success rates, but that's not actually practical nowadays. So IVF at Liv Hospital in particular, what's your approach? Like, is it IVF with intracytoplasmic sperm injection always?
Well, almost always intracytoplasmic sperm injection. Yes. Um, in Turkey, many IVF clinics are doing the same way instead of doing classical IVF. But if we have so many number of eggs, we sometimes do half ICSI, intracytoplasmic sperm injection, and half classical IVF if the sperm
Okay.
count is good.
Okay. Okay. Okay.
Almost always classical, I'm sorry, almost always intracytoplasmic sperm injection shortly.
Okay. And what's the typical, based on your experience and past patients, what's the typical IVF success rate that a couple should consider? Suppose if the age is between 30 to 35 and maybe between 35 to 40, what's the effect on the IVF success rate when it comes to age of both the partners?
Yeah, we don't see the effect of male age before 45, 47, but the
Okay.
female age is very important in IVF. As you well mentioned, the success rates should be divided related to the age groups.
Mm-hmm.
Uh, Under 35, between let's say 30 35,
Mm-hmm.
our success rates almost never goes down from 70% and can
Okay.
sometimes even reach 80%.
Mm-hmm.
After 35, it should even be maybe divided to 36, 37, 38. I mean 35 to 38, 38 to 40, 40 to 42, and after 42. Because every year after the age of 35, no matter what you do, there's a natural decrease in pregnancy outcomes, pregnancy rates, but still we don't go below 55-60% before the age of 40.
Okay.
And after 40, we suggest our patients to do genetic screening if the patient's conditions are meeting the genetic screening criteria. We select the embryos that are euploid, I mean that are chromosomally normal, and try to bypass the woman's age effect. So for the couples which genetic screening is done, we don't see the sharp decrease in pregnancy rates after 40.
Okay.
Number one reason of why fertility and pregnancy rates are decreasing related to female age is the chromosomal abnormalities in the embryo. They are seen more often as the age advances. So if you can select the embryo by genetic screening that is normal, and if you transfer that, you can bring the woman's success to the rates that we see, that we get under the age of 35. You can bring them close to the younger age group.
Okay, that's great. Because this, even I've heard for the first time from you that performing genetic screening on the embryo aged 40 years can actually increase the success rates by selecting those embryos that are actually healthy and placing them. So
Yes.
this was really very informational, and thank you so much for taking your time out. And we're going to collaborate again very soon, I'm sure, for another session where we can focus on a specific technique or a specific age group or a condition. Thank you so much.
You're welcome. Have a great
Thank you.
day.